I'm Dr. Caitlin Houghton. My uncle Pat got diagnosed with Barrett's esophagus and came to me for advice. In the last episode, Uncle Pat went to see his gastroenterologist, Dr. Apanagari, to discuss his Barrett's diagnosis. He recommended a watch and wait approach while controlling symptoms with medications. Today, Uncle Pat is getting a consultation with a foregut surgeon, Dr. Kemp. Let's listen in to see what she recommends for his conditions.
Hi, Uncle Pat. My name is Dr. Kemp, and I know you're seeing me because of the diagnosis of Barrett's. On your endoscopy, you have what we call a long segments Barrett's esophagus. So you have about 7 centimeters, the length of your esophagus, that has abnormal cells, and we call that non-dysplastic Barrett's esophagus. The whole length of that 7 centimeters is a precancer condition. And so part of what we try to look at is why do you have it? And also what is the risk that that precancer condition can lead to a cancer? The reason you got Barrett's, the number one reason is that you had undiagnosed GERD, reflux disease. And that means that acid was coming up from your stomach into the esophagus without you having symptoms.
I have side effects right now. Basically, ever since I've been on the meds, I'm very manageable.
You do have GERD, you just don't have symptoms from it. So I agree with that, with the exception of when you mentioned kind of the coughing and the throat clearing and the swallowing. So you have had the start of probably some swallowing dysfunction because of the disease that has occurred in your esophagus. And that is a symptom. So oftentimes when we think about, well, we don't have symptoms, it's not that you have that raging burning, the way other people describe it. But what you have is dangerous because you don't feel the damage. And so that's where most patients like yourself, the longer the segment of Barrett's, we have seen that they're less symptomatic. So the misconception is my symptoms are better or I don't need Tums, when in reality, you're actually higher risk than you ever were before.
We just heard from Dr. Kemp that patients with Barrett's esophagus can be less sensitive to acid reflux. Therefore, minimal heartburn symptoms can actually be dangerous, and that symptoms alone are an unreliable predictor of disease progression. This is a huge shift from what we heard from Dr. Apanagari, who seemed pretty reassured by Uncle Pat's minimal symptoms. Let's hear more.
We have to decide what's the chances of you transitioning to a cancer or not, because many people in your situation will never have cancer of the esophagus. But who's those few and far between that we need to watch closer or do something about? In my opinion, you fall into that closer pool because when you had that TissueCypher score, you're on the high end of that low risk. And what we found is that you're in a low risk score, but you're at a 5% risk. And that means 1 in 20 is your chance of progressing to a cancer. We didn't have that information and we put you in the general pool of 1 in 200 to now you're in a tighter pool of 1 in 20 people that could progress to a cancer. When we look at your score is 5. When we look at intermediate or starting to get high risk, 5.5 is starting to hit intermediate. When we hit above 6.4, we're in a high-risk category.
Once a patient has a high-risk TissueCypher score, their risk of progression to high-grade dysplasia or esophageal cancer is more like those with low-grade dysplasia. That means we may want to consider escalation of care, such as recommending a tighter surveillance schedule or even endoscopic eradication therapy, such as ablation. If you take into account all of Uncle Pat's clinical risk factors, such as long segment Barrett's, family history, and smoking history, and combine that with his TissueCypher score, his risk may be elevated enough to start considering escalation of care.
Most of the time with Barrett's, we talk about antacid therapy and surveillance. And I want to first kind of address why that is, because antacid therapy reduces the volume of acid in your stomach. So in theory, we will reduce some of that acid insult up your esophagus. And that is true. We do see anti-inflammatory effects with these antacids on the valve and improvement in acid-related injuries like esophagitis. You still have this toxic substance, whether or not it's soluble bile or acid, causing damage in your stomach. You just don't have as much of it when you're on the medication. So why we continue to surveillance is we haven't fixed the underlying problem. You're always going to have GERD even when you're on the medication. You just don't have as much symptoms, or no symptoms in your case. So much of what we do as surgeons is, yes, we want to manage the precancer disease, but how do we get you back to where you were normally, physiologically, and that valve functioning better for you? Common sense to us in a way that if you have a hole in a roof, you should repair the hole. Even if you don't know if a storm's coming, you should repair the hole in the roof. And the GI doctors may look at it as, well, we haven't seen a storm for a while. Is it really worth fixing the hole? Because then we have to do the work and the cost, and there's things that come with that repair.
In this section of the consultation, Dr. Kemp is addressing Uncle Pat's hiatal hernia. A hiatal hernia is when the stomach migrates up into the chest and displaces the valve that should be protecting the patient from acid reflux. A surgical hiatal hernia repair would restore the valve to its natural position and then reinforce it so that it can properly function to protect the esophagus from acid reflux. Acid reflux and injury to the esophagus is why you have Barrett's in the first place and why surgeons like to offer a repair to restore the anatomy and protect their tissues naturally.
Now we do know that ablation therapy, destroying the cells even when it's non-dysplastic, can help eradicate the disease in about 75 to 80% of cases. And you destroy those tissue layers and you allow those good cells to come up to the surface. For you, in my situation, I would recommend ablating and that we put you on a little tighter surveillance initially if you weren't going to have surgery. And if you have surgery, we're reducing your risk. We would still, what I would typically do is you'd ablate. We would see if you have eradication. If you do, we would move towards surgery. At surgery, then we rescope you at 12 months from your surgery, both to look at the structure and function of your new valve and then do biopsies. Many patients with long segment will have a decrease in centimeter length of their Barrett's, meaning less Barrett's. Now, long segments rarely regress completely at 12 months after surgery. But if you've already had an ablation, we're getting ahead of it. We're actually killing some of those cells, and we may have taken you down from a low segment to a short segment, and then we add surgery, and now we have a real shot of having no Barrett's, no precancer cells.
Dr. Kemp is recommending a treatment strategy that really focuses on regression of Barrett's. She recommends we do this by first ablating the tissue and then protecting the new cells from injury by doing a surgical repair of the valve so we can naturally protect the esophagus from reflux and injury. This is really different from what we heard from Dr. Apanagari, who was really focusing on symptom reduction with antacid medications and then ongoing surveillance. What's Uncle Pat gonna do? In the next episode, I get to sit down with both Dr. Apanagari and Dr. Kemp to hear more about their perspectives and how they shape their treatment strategies. You don't want to miss these incredibly informative discussions.